Thank you very much, and really nice to see the word practical there.
Good, I hope so. Can people hear me all right there? Right, so my interest is very much on trying to deploy learning health systems and work out how we can get the good idea of a learning health system into some practical applications in some given domain areas. I'm going to tell you very briefly about three things which my colleague Vasa and I down here have been working on. So first of all, I was kind of thinking that Chuck might do this, but this is the kind of latest working definition of what a learning health system ought to do. And I think it's worth reminding ourselves at this point, because I think this underpins the whole area. So it's capable of learning. What that actually means. What does it mean for a system to learn? Well, some form of updating. And that means some representation. All right. All right, good, okay. Transparency, providing reasons for recommendations, effecting change, tracing the provenance of an action and through data. That's an audible mechanism of doing that. That's one of the things that underpins learning. How is this thing working? That it's fractal, that it can work on lots of different scales across a health system, across Scotland, within an EHR system, in a integrated health system, in an individual general practice or hospital. That it's capable of meta-learning, that it's capable about learning about itself, which aspects of the system, which parts of a guideline are actually influencing change and which parts are superfluous. That it's capable of localization and adaptation, particularly in a global health context. Why do we apply knowledge from developed economies in developing economies? Well, you can't, but how does a developing health economy start to learn what works in that setting? And then it's capable of integrating multiple stakeholder positions. So this is what is at stake, and that's why this meeting today is so important. And it requires a physical infrastructure, data standards, and open interoperability. So let's move on. Okay. To an example here. I don't seem to have a pointer, but at least it's got numbers on it. So this is where we are currently with a learning health system for diagnosis. It's currently supported by Cancer Research UK. It's come out of an EU programme, and it's currently at a fully functional prototype which has undergone some evaluation, and we're now moving that into a real-world setting over the next couple of years. So if I start with number 1 down at the bottom here, you'll see there's a cycle around here. There's a learning cycle. It's coloured the same way that versions of the learning health system have been done. So taking performance to data. One of the key things that we've had the problem is you can't learn about diagnoses from electronic health records in primary care. They don't tell you anything useful because those records are not structured according to an episode of care model. You don't know why the patients come in, you don't know what the symptoms and signs were, you don't know what the end diagnosis was, and it certainly doesn't develop over time in a well-recorded way. So there's a structural problem. There's also a coding problem in that, and I could show you evidence of this, that GPs actually only record about 1/10 of what's going on, and that thing they do code is as a justification for the diagnosis that they've got in their head at that particular time. So it won't tell you anything useful. So in order to do that, we need to have a voice interface, which will get people to code rapidly and quickly rather than writing text, or we have to have really good NLP that works. We need to then link that data with other episodes, say cancer outcomes, COSD data set, all those kind of things. So that's very much NHS digital area. Linking perhaps patient-reported outcomes, apps, other sensors, that kind of thing. Put into a data set, do some machine learning and analytics. Here, interested in creating diagnostic associations which are adjusted for the overlap between those associations, and put it into a digital knowledge framework. So that's that top box 4, that really what we're talking about here. And I'm pointing this out to say that you can't look at 4 in isolation from the rest of this cycle. Then in 5, we're interested in picking up the phenotype, the information from the patient under consideration, and producing a different list of differential diagnoses, which is the way our system works. It improves diagnosis by reminding clinicians at the very start of a consultation what the potential diagnosis might be for this patient, and helps to prevent premature closure and bias in the information gathering. So that's the psychology part of it. There's a little box in the middle called provenance, where you can track what your knowledge is and how often it's being used. And also provide a kind of justification, a medical legal justification. This is what the decision support system was suggesting. Here is the ontology for diagnosis. It's a simple model based on Larry Weed's episode of care model. So we have reason for encounter. It has multiple potential differential diagnoses, which have cues, which can be signs, symptoms, risk factors, or test results. And that each of those has a multiple set of potential codes that can be linked to those as concepts and synonyms bound, and that there are relationships across that system which relate one to another, which could be anything from a simple association to a full-blown Bayesian network. Okay, so this, I think, is key, because one of the things that an ontology is about reasoning. So you can go from one end or the other. You can say, I've got this potential diagnosis, what are the potential symptoms and signs that might be associated with those? And you can go from a reason for encounter to a set of differential diagnoses. And that backwards and forwards reasoning is really important with the knowledge graph thing that you heard earlier. So, moving away from, just check my time, moving away from the issue of diagnosis, but moving into actionable guideline statements. So this is more the kind of nice area. I think the really tough thing here is about where there is comorbidity, where there are a multiplicity of different guideline recommendations, where there may be issues of prioritization. So, as a clinician, I work 1 day a week as a GP still. Sitting in my office with a patient in front of me, I've got pop-up boxes which are growing and growing and growing on each year. More and more things coming up. And I could easily, for a complex patient, look down at 15 different things on there saying you should do this, you should watch that, you should watch the range of the blood pressure, watch the latest glycosylated hemoglobin, and by the way, the patient hasn't had a screening test to see whether they're depressed and they need their flu vaccination. And you think, I can't do all of this. And the temptation psychologically is, I'm going to ignore it. And that's, I think, increasingly what's happening. So we need to prioritize, and we also need to work out where things are in conflict, either where guidelines are in conflict with each other, perhaps even internally, but also certainly between different guidelines, but also where a particular patient preference or some overriding issue is again negating part of the guidelines. And we need to provide an explanation for that rather than it just being a black box. So this is what this particular bit is about. So it's from Frank van Harmenen's group in Amsterdam, Zambolini, and it's the transition-based medical recommendation model, TMR, which is an RDF-based model looking at ways of representing guideline strengths of evidence, what a particular recommendation is going to do, and what thing will it affect. So it might be, for example, lower glycosylated hemoglobin in a diabetic patient and therefore reduce the risk of X complication, for example. That you can capture this in a robust and flexible way, and you can use these parts, these actions, these strengths, the property affected, the causation probability and the belief strength as ways of arguing computationally between the different parts of the guideline. And our colleagues in computer science at Imperial are working with an extra layer on top of this, which is an extra formal argumentation layer linking down into TMR. Once you have your things in TMR, you can do more interesting things with it from that point of view. So this is the Road to H project, which is an EPSRC global health project, and we're working, as if this wasn't hard enough, we're working on COPD management in Belgrade University Hospital in Serbia, and looking at the switch onto LABA combination inhalers, which is a big issue in Serbia, and it's obviously a big issue in the UK because it's a major driver of costs, and how those are working. And in China, in high-cost drugs for oncology in liver cancer and non-small cell lung cancer. So I'm going to spend a second on this. We've mentioned sorry, that's my time up. We've mentioned phenotyping several times. It's a special kind of phenotyping, finding patients for clinical trials. This is a transformed clinical trial management system, which is based around CDISC, operational data model, which gathers forms. What I'm showing you here is how you've got some properties on the left-hand side, so items which can be linked to an ontology to more clearly specify what kinds of clinical data we're interested in finding for a particular clinical trial eligibility. So another use of ontologies and learning systems, but bringing in that key bit. So bringing it together, I think there are common approaches here which allow a system to serve multiple purposes. So think about our existing EHR systems and infrastructures, and let's layer on top of that ontologies, knowledge models, knowledge graphs, models of workflow and provenance, better user interfaces, better, more flexible uses of APIs, version control, provenance and curation. They're all things that we need to be doing. And I think we can start perhaps with a few Pathfinder projects to push some really compelling needs within the NHS where all this community can work together in that area. Thank you very much.
Questions, please. Right.
Too much information.
Go on. I'm really interested in that prioritization layer that you've got there and this problem of not generating more and more problems and coming on the wrong side of the workload issue. Have you got a metric that can actually trade off? It's not worth telling them about this one or not, or do you fall back to heuristics like red lines and red flags, which is what we do in clinical practice?
At the moment, I think we're very much in that where we are now. Let's try and reproduce that. But I think in the future, you could start to produce more explicit thresholds about what in a given situation might come above that threshold. But it's a future thing.
Yep. Thank you, Marcus.
There's stuff that is the themes that have been talked about today tend to have been very sort of high level, making difficult decisions that perhaps previously the clinician would have made, and these things are about supporting the clinician making that decision and balancing lots of conflicting advice. And what I was sort of musing on was that I don't see so much emphasis on automating sort of the simpler little bits that glue all that together. So to use the hackneyed aviation analogy, for quite a long time it's been possible to have a gadget, a button in the cockpit that will say fly at this altitude and this heading. And the plane will just do that, which frees me up as the pilot to do more stuff, more clever stuff. Is there somewhere that I'm missing in where this kind of stuff is being used to automate those kind of more like trivial stuff, but stuff that will still mash up the gears? So in the clinical example, it would be, yes, we decided the patient needs to be on statin, but who's going to arrange that LFT in for 6 weeks, and who's going to look at it, and who's going to tell me if it's between these two numbers and act on it if recorded? That is the autopilot.
I completely agree with you. So where this is kind of coming towards is to start to build the infrastructure for that kind of health autopilot. When I've been in general practice for 27 years, and it has grown infinitely in complexity from generally one problem, one straightforward thing, one health area, to now patients with 5 or 6 different things that they want to raise in a particular consultation, plus a plethora of other things that you need to do. And I don't want to be wasting my time actually printing a form out, saying, okay, I'm starting on statin, we're going to need to check this in 6 months' time, or gosh, next week for some U's and E's because I've titrated your dose up, a race inhibitor. And that's taken up all the time. And then there's barely time to start thinking about what's my prioritization in all this, and actually find time to talk to the patient. So I completely agree with you. We need to take pressure off clinicians, automating the simple stuff, making it transparent, and allowing us to think at that higher level.
Thank you.
Thank you. Brilliant presentation. Just on that last question, I was recently at the BCS Primary Healthcare Specialist Group conference, and there was a prize winner who'd done some amazing work with templates in a GP system that did a lot of what you've just been describing. But of course, the problem is it's locked into that particular GP system.
Yes.
But this bigger picture of which we're all here for today, the transferable knowledge between
Yeah.
multiple systems is where we need to get to. But at least at the kind of practical interim level, I think a lot of the thinking has been done by some of these very clever template generating people.
Yes, and there are some quite clever people that work in clinical aspects in the different EHR vendors who've been doing just that. Absolutely agree.
Thank you.